Welcome to the Metabolic MD. Health means everything. We all seek optimal health, but most of us do not know how to achieve it. Dr. Paul Kolodzik has spent a career in the emergency department. Now, he helps his patients avoid ever ending up there. During these podcasts, you'll learn how you can lose weight and prevent and reverse disease through new technology, a modified diet, and the use of some new recently approved FDA medications. This information is not meant to be medical advice. Please seek consultation from your own medical provider. Let's listen in.
We want to thank our following sponsors, themetabolicmds.com, a boutique weight loss practice focusing on weight loss through modern technology, the latest GLP-1 weight loss medications, and health coaching. We also want to thank the CGM Doctor, where you can purchase a CGM without a prescription delivered right to your door and also find useful information to get the most from your CGM to improve your health and weight.
Dr. Paul, we're back. I like to call you the man with the medical knowledge. And today we're doing a combination of different topics. We're calling it the potpourri of what's going on out there in the healthcare world.
So are you saying that I know a little bit about a lot of topics as opposed to an awful lot about a single topic?
Which one's better?
I don't know. So actually, there's some pertinence here, like with my work in the emergency department, in that you got to know a little bit, at least enough to be functional in the first, 2 to 4 to 6 hours of an illness about everything.
Yeah.
Pediatric fever, a woman having gynecological or obstetric issues, a patient with a heart attack. So you got to have, a certain depth of knowledge about lots and lots of things. And quite honestly, I like that. I like that approach as opposed to, there are physician specialists that focus on, here's an example, the retina. So not only the eye, not only an ophthalmologist, but somebody that is a retinal expert, which is, a tiny area of the body.
Yeah.
So, I mean,
but you're kind of an expert in the metabolic area.
I guess I am. I don't give myself enough credit.
You don't.
You're right.
Let's give you credit.
Yeah, you're right, because there aren't a lot of people in the country that really have focused on that the way.
Now that we're in the top 5% of podcasts, we should give you the credit you deserve.
Yeah, that was nice to see.
Yeah, it was nice to see.
Yeah.
All right, so as the potpourri of medical topics go, and we're going to hit all kinds of different things. I mean, we're not staying in one lane. We're jumping around a little bit today, right?
Yeah. And the way this really came about was, I focused over the last few years, and you know how your news feeds get curated so that, whether you're doing Google or whatever, you get sent stuff that you're interested in.
Right.
And so that's what's happened with me over the course of the last few years as I, on a daily basis, review primarily clinical and healthcare industry related items. And I'm coming across a lot of interesting things, both related to metabolic healthcare, related to emergency medicine, related to what's going on in the healthcare industry. And I just felt kind of a need to share some of these things with people because I think they would benefit from this bit of information as well.
If you have the need, we have the desire. So please, what's our first topic of conversation?
So the first thing I came across was an article about a PhD doc that I've heard lecture at some of the metabolic health conferences. And this gentleman's name is Ben Bikman. And he's it's Bikman, and he's at Brigham Young University. And his area of research, he's a PhD, his area of research is fat cells.
Fat cells.
So he focuses on fat cells and what's going on with fat cells related to metabolic health. So a lot of what he does looks at the topic of insulin resistance that we've talked about for years.
Yeah.
And what he has found in some of his research is that once people are overweight, their fats, you can shrink those fat cells by, doing the things that we do with patients, low carb diets, Intermittent fasting, strength training helps with that because it reduces insulin resistance. But those fat cells are going to have a memory of you being overweight. And so that's why it's tough for those individuals that have previously been overweight to keep the weight off, if they regain weight, to lose weight again, because those fat cells remember what they've experienced in the past.
So what does that mean? Does that mean they're like elastic? It means you've stretched them out so that they just want to go back to where they were when they're fat?
Well, I think it has to do more than that. I think it has to do with this term epigenetics, which means kind of how your gene sequences can get modified within a generation or two, and basically then your cells can respond in a variety of different ways. And remember, Terry, from an evolutionary standpoint, our bodies want to be fat.
Sure.
They want us to be fat because up until the last 100 years, fat meant an increase in survivability. It's really only in the last 100 years that fat really has been more detrimental.
Yeah, when the Gilded Age, wasn't it like you were more attractive the heavier you were, kind of thing?
The Renaissance stuff and the painters. It's
the Rubenesque.
Yeah, because those people were likely to survive longer. The kings and the queens were overweight because they were the ones that had access to more food. So it's a really interesting topic. One of the things that Dr. Bickman mentions is that babies are fat for a reason. Babies come out with an extra layer of fat. Not all animals or mammals are born with this extra fat, but human babies are born with this extra fat to improve their survivability during the neonatal period.
Well, wouldn't that be because we're not coming out with fur to keep us warm?
I don't know. We do have fur. We're mammals, so we have hair.
I don't have.
Yeah,
you
don't, Terry. I'm sorry. Yeah. I was thinking about that
That's
as
a
I
sore
said
topic.
that. Yeah.
All right. So, are we done with Dr. Bickman? Or you got
no? Other than he's written a great book that I just want to mention to people because it's all about insulin resistance, and it's called "Why We Get Sick." It's very popular on Amazon. So when you're on Amazon looking for the Continuous Glucose Monitor Revolution book that I wrote.
Oh, there's a plug, yeah.
Then have a look at Dr. Bickman's book as well. And I'm just plugging him because, first of all, after hearing him talk, he's a brilliant guy, and he's really focusing on a badly needed area of research. And he has written this book, which is really good, again, focusing on insulin resistance. And again, the title is Why We Get Sick. So why don't you have a look in Amazon about that?
All right, what's topic number 2 of this potpourri of medical knowledge?
Topic number 2. We're going to talk a little bit about what's going on in the healthcare industry these days.
You mean from a business point of view or from a medical point of view?
Well, it's a business point of view, but it impacts people as they seek health care, and how the care they are provided is impacted by these industry and business forces. Okay?
I'm lost, but keep going.
Okay, so let me give you an example of this, okay? Private equity, which is, investment companies, have become big players recently in the healthcare industry. And so, for example, in the last couple months, a private equity firm that bought up a bunch of hospitals on the East Coast went out of business. And so these hospitals that had been in business for many, many years serving their community actually had to shut down. One of these happened, my son lives in Philadelphia, one of these happened in a suburb of Philadelphia.
So these guys bought I thought hospitals were nonprofit. I didn't think the hospital had
No,
share
there are for-profit hospital chains. And a lot of times what happens is the not-for-profits, because, they're small individual, not part of systems, they get in financial trouble. And then they have to seek a way to stay open, and the private equity investors come in and invest in the hospital, and prop it up and try and make it work as an ongoing concern. But sometimes that doesn't work out because, if you're an investment bank, you really are focusing on,
money.
the bottom line.
Yeah. So why did it fail?
I just think they had cash flow issues. They didn't make the capital investments because that would have decreased the profitability of the private equity fund.
So they're not investing in the latest technology. They're not investing in all the testing systems that they need.
So this is kind of the point I wanted to make in bringing this topic up. Is that private equity is involved, and I'm not saying private equity is evil, but it's hard to serve two masters.
I'm saying it right here.
Yeah. It's hard to serve two masters. And so if you're seeking, a return, it's maybe sometimes difficult to provide the care. Now, the majority of hospital systems are not for profit, but, they also have to have a profit in order to continue their mission. And a lot of those hospital systems have big foundations,
right,
with lots and lots of money. So I'm not saying one is good and one is bad, but if you're involved in getting health care from a private equity entity, you should at least be aware that that's out there in the background.
How, if I'm going into a hospital, I could be going in on an ambulance, but how would I know?
That's what ChatGPT is for, Terry.
Oh, as I'm getting wheeled out in my little cart, hey, ChatGPT, which one's a private equity firm or hospital?
So, for example, over the last 3 years, 2 physicians that I go to have had their practices purchased by private equity. The dermatologist that I've been seeing for 15 years, her practice is purchased by a private equity group.
I can't tell you how bad I think that is.
Yeah.
I mean, they're going to try to drive down costs. Every business has to drive down costs, but those guys really are in there to make money.
Yeah.
And I don't want people making money off my health care.
Yeah, I'm not going to say it's inherently evil. I'm just saying people should be aware of that. And, it's a different story. When I got out of my residency in the mid-'80s, docs at that point, they were pretty much just small groups hanging out at a shingle. And now all the docs are either owned by private entities or working generally for hospital systems.
Sure, that makes sense.
Where they aren't their own bosses
anymore. They aren't, but then they're tied into referral systems and things they can get access to because they're part of a larger group. But that's not private equity. Private equity.
No, that's just not. So the distinction is, okay, in general, there is there are for-profit hospitals, there are private equity-owned hospitals and medical groups we're talking about, and then there's not-for-profit. So, it's just not a bad idea to have that information in the back of your mind when you're seeking medical services.
All right. Well, let's go on to what's our next topic of this potpourri of knowledge?
Well, this one hit me this week. This was an article in the Wall Street Journal, and this is something that I believe is coming. And the title of the article was, America's Hospital Bed Shortage is About to Become a Crisis. Okay.
Keep going.
Okay. So...
and by the way, it's not a bed shortage, it's a staffing shortage.
Good point, Terry. Man, you hit the nail on the head there.
I have so many doctors coming down here for these. I learn so much from you guys. That's what they tell me.
But it is. And it's a shortage then a lot of times. So the euphemism in the hospital setting has been, oh, we're full, we don't have a bed.
Right.
When there's a floor of beds upstairs, but there's not nurses to staff them.
Right.
Yeah. And so that is not unusual or infrequent.
But you walk into a restaurant, you see plenty of open tables, but yet they go 15-minute wait.
Yeah.
And it's not because they don't have a table, it's because they don't have the waiters or waitresses.
Yeah. So, and this kind of wraps into the topic we just talked about. It's like, the hospitals, I think, at times are operating on very narrow margins, and they got to be very careful about their hiring practices and how many nurses, because if they have full-time nurses and then their census drops, then that is a cost profitability issue that they have to manage. So they try and keep things lean and mean. And so this impacts me on my weekly work in the emergency department. Okay. Because at the facility I work at, we don't have all specialties. We don't have neurosurgery. We don't at times have gastroenterology on call. We don't have ENT on call. And if I have a patient that needs one of those specialties and require a hospitalization, then I need to find somewhere to send them.
Is that you physically doing it, or is there an admin sitting behind the curtain that you go, hey, Janice, can you find this for me?
It's a challenge. I'm just going to tell you, it's a challenge because, you know, what I want to do is try and get them admitted there. Maybe the hospitalist says, no, we can't admit here because we don't have this backup. And then it falls back on me. I'm responsible for finding a place for there to go. So do I have a ward clerk or a secretary helping me? Yeah. Calling around. But I can tell you, the reason this article kind of struck my interest is because I will tell you 5-8 years ago, you know, it was easy. You know,
is that because kids aren't graduating with nursing degrees? What's going on?
No, I think it's that the hospitals are trying to run lean and mean to avoid financial issues.
See, I'm going to argue with you here. Sorry, guys, but I'm going to argue. So we in our little small town of Dayton, Ohio, right, which we're like the 4th largest city in Ohio, you will see banners, sponsorships, all kinds of money going out to things that are not related to my healthcare. It's just to get my attention, right? So if they have the money to do that, they have the money to hire nurses and things like that. So I'm going to argue that they have money, they're just not spending it.
Well, that they certainly have foundations that have money, lots of money. I think there are many hospital systems that have foundations with billions of dollars. That's with a B.
Oh yeah.
In them, but they're running mean and lean, and a lot of this has to do with government policies. Like you hear, I know you're a big fan of the big beautiful bill that's coming, Terry.
Oh, it's crashing like a big turd. It is. Go ahead.
Terry and I come from different sides of the political spectrum at times. But, you know, one of the big discussions there is cutting back Medicaid.
Oh, I know.
You know, and which...
was it 11 million people will lose their health care?
Yeah, but you got to remember Medicaid was greatly expanded over the last 4 or 5 years as well.
Well, it wasn't expanded because you needed it?
Well, I think during the pandemic, that's true.
Yeah.
Yeah.
Okay.
So we don't need to get into the political nuances of that discussion. But, you know, the hospitals are concerned about Medicaid being cut back. And I can tell you from my history in a private emergency medicine group that basically, you know, Medicaid doesn't pay very well for either hospital or physician services, but it pays better than an uninsured patients because uninsured patients, of course, just don't have the money to pay for services.
What will happen? I mean, just kind of curious. If they kill, let's say, 11 million people go off of Medicaid, what will those people do?
Those people will still get services because
so if they walk into an ER, they get services. You can
walk into an ER. You know, there's something called COBRA, the COBRA Omnibus law that was passed in the 80s that says emergency departments are required to evaluate and provide services to people. So,
but do they get billed? I mean, does that force them into bankruptcy?
Yeah, they'll be billed. But there are also now certain laws related to whether patients can be sent to collections. So I'm not up to date on all of that.
Holy cow!
Yeah, but it squeezes the hospitals and the emergency physician groups because you got to be there staffing.
Yeah.
You know, and you got to have revenue to pay doctors and nurses.
Won't that just kill ER departments? Because now they're just going to turn to the ER versus trying to get health care.
Well, you know, we're digressing here a little bit, but there have been large national emergency medicine groups over the last 3 or 4 years that just went out of business.
Really?
Yeah. And, you know, the doctors, you know, the doctors eventually had to be transitioned to either hospital employees or whatever, but you know, they went out of business. So, but let's get back to this issue of a hospital bed shortage.
Yeah.
You know, based on the trends I've seen over the last 5-8 years, this is coming. What it means to me practically in the emergency department right now is that it's harder and harder to find somewhere to send a patient that needs a specialist. You know, you try and say,
Sorry, my alarm went off. Go ahead, keep going.
Okay. Your blood sugar okay there, Terry?
Blood sugar's fine. That was my alarm to say it's time to take a shot. But I did that earlier because I knew we were going to do this.
Okay. All right. It's just getting harder and harder for you know, and you know, see this scenario that I deal with on a not infrequent basis. I've got an elderly patient, and they need specialty care somewhere. I call the 2 or 3 local hospital systems. They say we're full. We don't have a bed. Now I have to go shopping. I got to go shopping elsewhere in the state, or even at times out of state.
Really?
To find a place to transfer this patient. And, literally this is the sad scenario. So that's, an elderly person. This is the normal scenario. It's an elderly male.
Yeah.
And their elderly spouse is there. And the spouse, is often the driver. And it's like, I've got to send you 90 or 120 miles away. And of course, what does she do? Is she going to,
oh God,
I mean, it's really heartbreaking at times.
That would be, now, isn't there, I've always heard there's a rule that if somebody comes in on an ambulance, they have to take you. True?
Well, you've got to be seen in the emergency department.
Yeah. So could that guy not get up, fall, or call 911 close to a hospital he wants to go to? They take him there. They have to admit him, right? They have to bring him in.
Yeah, I mean, but I can't do that. What if it's a potentially unstable patient?
I've learned that a long time ago. Don't go to the ER and walk in. Call 911. You go right to the front of the line when you get there.
That's not always. I mean, there are people that play that game, Terry, and I'm sure your devious mind would come up with that.
When I was having a heart attack, my wife said, "I'm not driving you. I'm calling 911."
Yeah, well, that was probably a good move. Yeah. Your wife's a smart lady.
She's way smarter than I am.
Yeah. So at any rate, I think this is, they say the cutoff when things start getting squeezed is occupancy rates in a hospital of 85%.
You mean actually 85% of beds are full?
Yeah. And when it starts going over that, that's when you're going to have these peaks and valleys of shortages. And according to this article, this is just going to get worse over coming years. And of course, demographics with the baby boomers aging is going to drive this
what can be done?
I think it's a tough situation. On a micro level, what can be done? What can be done is you can do the things we've been advocating for the last 7 years.
Oh, stay healthy.
Stay healthy.
Yeah.
Yeah. I mean, that is your best move.
Okay.
But other than that, you are a little bit at the mercy of the system, to tell you the truth.
It really sucks.
Yeah. Yeah.
It just seems like somebody should figure out how to fix this stuff.
Yeah. Well, it's money, Terry.
Yeah, I got that.
Yeah. So these are the good old days in terms of
right now we're living in the good old days.
Yeah. I mean, yeah. Because
so we'll look back upon this and go, "Wow, it was great back then."
I think it's. I mean, I hate to be, what is it? Negative, or
Dr.
the sky
Glumchum.
is falling. Yeah. Whatever. But again, I think the message there is, let's take care of your own health, control the variables you can control. About 70% of your health is something that you can control,
right?
Without the medical system. There's some people that are unlucky, get a cancer that they have through no fault of their own.
Oh God.
But but control what you can control. So but even like, this is an appropriate topic, there's a lot of cancers that are related to obesity. So
yeah, that'd be actually an interesting topic for a podcast.
Yeah, I mean, one we've talked about here is fatty liver disease, which can lead to malignancy.
Wow.
So, and liver failure.
So do we have any other topics for this potpourri?
We do, but why don't we save them for the next time around? Okay?
For the next potpourri?
The next potpourri.
I actually enjoy these potpourris. I learn a lot during this stuff.
I think we're going to do this more, and we'll see what kind of response we get from people.
Yeah, by the way, if anybody ever has a question or a topic that you'd like Dr. Paul to cover, we're always open for ideas. Please send it to what's a good email
so
address?
You can either you can go to the websites and you can email us at metabolicmds.com. That's my medical practice. Or you can go to CGM-Doctor, which is the site where we provide CGM education, primarily to focus on CGM use by non-diabetics. Right. So you can contact us at either of those places, send us a topic that you want to hear about, and we can have a discussion.
All right. So why don't we end this one for right now, and then we'll come back with another fun-filled topic in a few days. All right.
Thanks, Terry.
All right. Thanks, Dr. Paul. See you all later.